Hi, I'm Tyson Franklin, and welcome to this week's episode of the Podiatry Legends podcast. The podcast designed to help you feel, see, and think differently about the podiatry profession. With me today is James Ferrie, the owner of My Sports Podiatrist in Melbourne, Victoria. James is an experienced musculoskeletal podiatrist, and he was previously on the podcast back in July 2025. That was episode 375, titled Shockwave Therapy Secrets, What Most Podiatrists Are Missing. Today, we're going to be talking about ultrasound-guided nerve hydrodissection, regenerative medicine. So, James, welcome to the podcast. It's good to have you back on Podiatry Legends.
Hey, Tyson. It's good to be back.
What I'm noticing too, when we're talking about something that's a little bit more technical, the podiatrists just eat that stuff up.
Yeah.
When we're talking business, it's a certain group of people that like that. And when we're talking about other people's stories on podiatry, how they got in and what they've been doing, it's in between there. So, technical, podiatrists eat it up. Business, it's a select group, and then you've got stories in between.
Yeah, that it is interesting. I've had a lot of the last recent conferences I've been to. I've had quite a number of people come up and ask questions about, particularly that podcast on
Cool.
Yeah, so it's definitely getting out there.
Well, that's what I tell everyone. When you're listening to an episode like this one or any other one, if you hear a guest and you go, "Oh, that was really interesting," whether it's technical, whether it was business related or a story, if you really enjoy it, please reach out to the guest and tell them, send them an email, hunt them down and just say, "Hey, I listened to your podcast, really enjoyed it." Because I know when I get feedback, it's, pops your wings up a little bit. So I know everybody else is exactly the same. They come on here, share their information. So I think they like to know that people are taking it on board.
Yeah, exactly right.
So today, let's dive straight in. Let's get onto this particular subject.
So have you ever come across or heard about ultrasound-guided nerve hydrodissection?
Only through you.
Yeah.
Only you mentioned it. And I have heard people talk about similar things, but that's why I've got on here to get into it in a bit more detail.
So I guess my sort of journey into this whole space probably started about 10 years ago, where I think I started doing a course with a prolotherapy doctor who probably a lot of podiatrists were trained by, Dr. Margaret Taylor down in Adelaide. She used to run a one-day sort of workshop on prolotherapy. And I remember going down to that when I was fairly newly graduated. And it's a pretty crazy course. She's got some live patients. She's doing all these injections. And to be honest, a lot of it sounded too good to be true. She's using effective local anesthetic and some glucose, either hyperosmotic glucose, where you're trying to create sort of proliferation of cells, or also using isotonic, which is 5% dextrose, which is what we use with nerve stuff. And I remember going back to clinical practice, and for some of those patients where we might have tried orthotic shockwave and rehab exercises and reached a bit of a plateau and we couldn't quite get the result that the patient wanted, I tried some of these techniques, and to be honest, I was pretty blown away by the effectiveness. So from there, that's changed my sort of journey a little bit in podiatry. And after that, I spent some time with Craig Wanless up in Noosa. He's a pod up there, and we actually teach quite a bit together now. And Craig Wanless has gone down that same journey and was at that point starting to use some PRP and some of the regenerative sort of cellular therapies. So we did some work there. And then I ended up heading over to the US and doing some stuff with the Interventional Orthopedic Foundation over there. So they teach effectively doctors techniques under fluoroscopy and ultrasound, because regenerative medicine has it's a paradigm shift compared to like conventional radiology based pain management, where you put cortisone where the pain is worst. So you think about that sort of traditional approach, which is more of a pain management approach. You have someone who has a sore plantar fascia, for example, and you might have tried some conservative things, hasn't worked. You send them to radiology or a sports doc or a podiatrist, and they inject some cortisone into where it's sore. Now, that does help in terms of reduced pain, but being a drug, it's temporary. And we know that the sort of underlying disease process is more degenerative as opposed to an inflammatory pathology. So although you can use medication to manage symptoms, it doesn't always resolve the underlying issue. So regenerative medicine is a bit of a paradigm shift in what we're trying to do often is stimulate some acute inflammation in order to restart the healing process, because a lot of the conditions we see, such as osteoarthritis and tendinopathies, they're degenerative in nature, which are associated with aging, as opposed to something that's inflammatory, like a ankylosing spondylitis or rheumatoid arthritis, or something where there's an autoimmune process that's causing inflammation. So that's how it started.
What I like about what you said then too is you had that initial course in Adelaide that sparked your interest. You did the initial course, but I love how you kept that journey going. You didn't just do that course and that was it. You then obviously hunted around what was happening in Australia, what was happening overseas. So you've caught up with Craig Wellness in Noosa, but then also looked abroad and you spent the money and you gave up your time from your practice to go over there and learn more information. And I think people need to take that on board, that if there's something that really interests you, is you've got to put the time, money, and the effort into learning more to get better at it.
Yeah. And people are really pretty generous with their time. At the same time, I remember I reached out to Professor David Connell. He's the head radiologist, or I'm not sure if he still is, but he still works at Olympic Park. He was one of the founding members of imaging at Olympic Park. And he was really generous with his time and let me set in and watch him do a lot of his sort of biologic procedures with superkine and PRP. And he was always respond to emails and questions that I had when I was early in that journey. And so from there, I realized that what I'm going to need is ultrasound. So I think in one of the episodes we did quite a while back, we spoke about the use of ultrasound in podiatry. And it was effectively, it was that journey into regenerative medicine where I was like, I need ultrasound because I need to be able to visualize the structures that I'm seeing. And I need to be able to place that, my injectate where we want. So that's actually how I learned. That's where ultrasound come into it. I went into ultrasound thinking that I was going to use it primarily for injections. But at the end of the day, I found you can't do this sort of work without having really good ultrasound skills from an assessment point of view. Because when we're doing some of these procedures, we're not just doing an injection in one place where the pain is, we're often treating that whole segment. So for example, and we'll talk a little bit about the nerve hydrodissection, but I might be seeing someone who has, say, chronic plantar fasciopathy, where there might be some sensitization and some neuropathic symptoms that are starting to present. They might have an intrasubstance tear, some subenthesial bone marrow edema. These things are actually more complex syndromes. They're not just plantar fasciopathy. So I'll often be doing multiple things. We might be doing hydrodissection of the tibial nerve with a block, hydrodissection of your infracalcaneal nerve, your medial calcaneal nerve, then doing an injection into the plantar fascia and then hydrodissecting the fat pad. So, and sometimes we're also treating the other structures that might be involved. So there might be deficiency of spring ligaments, so we might be injecting that, or long plantar ligaments as well. So you really need ultrasound to be able to properly assess that whole segment. Yeah.
And to know exactly where you're putting the injections as well.
Yeah.
Because you can't. Is there anyone who's trying to do this blindly without using ultrasound, or that would just be crazy? I thought now would be a perfect time just to jump in and remind you to go and have a look at the podiatrylegends.com website or my personal website, tysonfranklin.com, if you want to see what events I've got coming up this year. Now, some of the events I run myself, some of my own workshops and masterclasses, but also speak at other conferences, which I list in the same area. So please go to podiatrylegends.com or tysonfranklin.com, click on events, and you'll get to see all the details there. Okay, now let's get back onto this interview with James Ferrie.
Yeah, look, traditional prolotherapy is effectively done based on clinical palpation, but I think nowadays, with the accessibility of ultrasound, I really don't think it is. Look, I personally find that ultrasound is so powerful, and if you're not utilizing it from a medical legal point of view, you're putting yourself in increasing risk. So back in the 60s and stuff like that, when prolotherapy might have been used, well, there wasn't easy accessibility to ultrasound. But nowadays, there's really no excuse. You've got handheld ultrasounds that are on the market for quite a low cost. They're sub 10K. But if you really want to do this stuff, you do need a higher end ultrasound with higher resolution.
Yeah, no, that makes total sense. And because I've seen on your website, you actually have a proper large ultrasound unit.
Yeah,
that you use. But are the handheld ones as effective or not as effective?
So it's one of those things like you get what you pay for. The handheld devices are, it depends on what questions, like what clinical questions you have. So if you want to look at something like, is the plantar fascia thickened? Is the Achilles thickened? Is there evidence of an intrasubstance tear? You can answer those sort of questions with a handheld ultrasound. But if you want to, say, do hydrodissection of the infracalcaneal nerve or Baxter's nerve, these are nerves that are often less than a millimeter in diameter. So with a handheld device, you're not really going to have the resolution to see that nerve.
Mm.
You're going to see the tibial nerve, and you're going to see maybe the difference would be like your sort of point and shoot camera
Yeah.
versus like a digital SLR. So with a higher end device, ultrasound, you've got more ability to optimize that image. So when you're looking for more subtle, detailed, small nerves and things like that, it's a big difference.
Yeah. Like you said, it's what you're using it for in a clinical situation. You're just identifying something that's simple, handheld, something more complicated and smaller. You've got to use the bigger equipment and the better
Yeah.
equipment.
And I think at the end of the day, it depends. It really does depend on that sort of clinical question you're asking. And for a lot of practitioners and a lot of podiatrists, doctors, the handheld devices are a great sort of gateway drug to get you into that space because
Yeah.
there's a relatively steep learning curve with ultrasound and learning it. So having access to an ultrasound to be able to practice your skills. And to be honest, when you use an ultrasound that's not as fancy and doesn't have as nice image quality, you really have to work harder for that image quality. So it actually does tend to make you a slightly improve your skills more so than if you just got a really nice device. But even with a nice device, the hard part is you still have to find that target, you still have to optimize the image, and that's really the first step. So when podiatrists go from doing clinically guided injections to ultrasound guided injections, it's a really disorienting. And if you feel like, there's a lot of practitioners I know who they feel pretty confident. I can do a plantar fascia injection, I can do a tibial nerve block. It is like learning the skill for the first time again when you start using ultrasound. You actually feel like you go backwards, and it probably takes you about 20 to 40 injections before you feel that you can reliably and you feel like you've got that confidence and you're moving more into you've got that skill set a little bit more mastered.
What makes that change so difficult?
So the difficult part is there's a few things. So firstly, you've got to really have your image optimized. You've got to be set up properly before
Yeah.
you do the injection so that your target is really nice and easily visualized. The second is that when you're doing what's called an in-plane injection, where your needle is basically passing in line with the probe and we can see the needle along its course, the width of that ultrasound beam is about the width of a credit card. So your needle
Okay.
has to stay within that width the whole time, or you can't see it.
Aha. Okay.
So you can lose it really easily. So you can get lost. And then the other thing as well is the steeper the trajectory of your needle, the basically the angle of incination. So the angle that the ultrasound hits the needle is affected. So it makes it harder to see the needle. So it can be quite difficult to see. Superficial injections are a bit easier because the needle is more basically parallel with the transducer. So it gives you a crisper image. And then the other thing as well is that the gauge of the needle you use is also basically the higher the gauge needle, the harder it is to see because it's thinner. So if you use an 18 gauge needle, it's
Yeah.
pretty easy to see that. If you use a 27 gauge needle, which is what I use for a lot of things, it's much harder to see a 27 gauge needle. So your skill set needs to be it needs to be more precise.
So you've got to maintain the ultrasound and doing the injection at the same time of maintaining
Yes.
the sight of it.
Yeah, and then the other thing that's a bit disorienting is with an ultrasound guided injection, once you'll look down and you'll put the needle through the skin, and that's the last time typically you'll look down, then you'll look at the screen, and then everything else is like
Oh
a
yeah.
video. So that's the part that can be a bit disorienting. It takes a bit of a leap of faith to actually watch a screen and watch your needle, and as opposed to actually getting a sense of where it looks like on the body.
And the other part too, I think like with ultrasound in general, is just interpreting what you're looking at.
Yeah.
I remember the first time I ever saw an ultrasound image and they're clicking and marking everything. And I'm going, what? It was like looking at a foreign language. Could not understand a thing.
And I guess the hard part at the start with when you're learning ultrasound, the first thing, it's one thing to interpret a nice image that a sonographer's taken,
Yeah.
but you've got to be able to acquire that image. And
Yeah.
that's the learning curve. It's not the interpretation, it's the actual ability to replicate that image and to find the target structure to optimize it so that you've got the right focus and everything looks as it should. Because if you're occasionally I'll get someone will send me an ultrasound image that they've taken with their handheld. And sometimes it's just not, they'll ask whether it looks like there's a tear or something like that. And sometimes it's just not of high enough, the image isn't optimized enough to make a diagnostic call.
So there's a lot of skills involved.
There is a little bit. So one of the, there's a, so the first, so we can break this up. So with regenerative medicine, we are effectively, as I said, with regenerative medicine, we're trying to cause some acute inflammation in order to restart the healing process in a tissue that's degenerative. So when you think about ligaments, tendons, fascia, these are structures that are very strong, but they inherently have a very low metabolic rate. And they don't have necessarily an internal vascularity to them. If you think about it, a tendon would be mechanically suboptimal if it had lots of blood vessels running through it. That would create weak spots within the tendon. Yeah. So a tendon or a fascia, the metabolic rate is roughly like an eighth to a tenth that of muscle or bone. So when someone breaks a bone and you put it into a cast or you put them into a boot because it's a relatively simple, uncomplicated fracture, they tend to heal pretty well. Someone tears a muscle, they tend to also heal pretty well as long as it's like an intramuscular tendon. The difficulty with fascia and tendons is these are relatively avascular, low metabolic rate. So they don't heal all that well if you put them into a cast or you immobilize them. Someone might have a tear in their plantar fascia, you put them into a moon boot for 4 to 6 weeks, they come out, they still have heel pain. It might be better to a degree because there's been a bit less inflammation because it's been immobilized. But as they start getting back into activity, you still have the problem. It's not like it's completely healed. So regenerative medicine focuses on restarting that healing process.
Okay.
Now, there are different ways that we can do that. So the first way is prolotherapy, and prolotherapy dates back to the 1930s. And it was basically a spinal surgeon back in the day in the US who hypothesized at the time that they used to use for hernias, they used to inject a sclerosing agent. So something that would cause scar tissue as a non-surgical way to try and scar up the area where the hernia was coming out of. So he hypothesized that a lot of lower back pain and a lot of back pain in general was more so associated with effectively ligaments that had become lax or loose because of either repetitive strain or injuries. And that then creates instability. And instability effectively destabilizes the joint, so you get more wear and tear. So you get a faster progression of osteoarthritis. So like everyone would see the patient that's had a really multiple significant ankle injuries, that'll be the ankle that will often develop some post-traumatic osteoarthritis. That people that have ACL injuries will often go on to develop osteoarthritis. So ligament injuries destabilize joint segments, and that can lead to more wear and tear. So prolotherapy uses a solution of glucose, which is hypertonic. So it's stronger, it's at a higher concentration than what's found in the human body. A little bit of local anesthetic and saline to basically get the dilution right. So we're typically using percentages of 10% up to a maximum of like 25% glucose. And the mechanism is that it creates osmotic stress when it's injected. And that actually causes a biochemical response in the tissue, which causes a proliferation of things like fibroblasts and tenocytes.
Yeah.
So you're effectively wakening the body up to a new injury. So if someone's had repeated ankle sprains, they've got some laxity, but the ligament's still intact, or they've got some chronic pain, we'll often inject not just the one ligament, but we'll often inject the whole structure, so the stabilizing structure of that joint. So this is why it's a little bit different to, say, a traditional approach might be someone has ankle pain and they've had repeated ankle sprains. You might do a cortisone injection into the ankle joint. With prolotherapy or even PRP, and PRP is effectively prolotherapy, but it's using the patient's own cells. So what we're often doing with PRP is taking some blood. That blood's then spun in a centrifuge, and we're injecting a more concentrated solution that has a high concentration of platelets, because platelets are loaded with growth factors when they're injected. So we use those to basically restart that healing process. Because when
And
you
you're
naturally,
doing that as well?
I used to do a lot of PRP. When I moved, there was changes to the TGA, which made it very difficult for podiatrists. It used to be a space that was not well regulated. We're looking at in the new, basically over the next few months, collaborating more so with, I've got a friend who's a interventional radiologist, and we're joining forces to create a regenerative clinic where we'll be offering high dose PRP.
Okay.
So looking at some stem cell stuff. So yeah, really interesting sort of space there. So he brings a whole nother skill set with cryoablation. And yeah, so Dr. Amit Lakkaraju is an interventional radiologist, does a lot of pain management stuff. So that's a project on the this year that should be up and running at some point.
What you're saying there with regenerative medicine doing the injections, say ankle joints, for example, is when you've done the injections, do they then have to stop activity for a certain period of time, or can they continue? So say, for example, I'll use my own ankle as an example. Multiple ankle sprains. Yeah, I still do Muay Thai at the moment. If I was to get that treatment done, do you have to stop your activity, or can you just keep maintaining what you're doing?
So we do typically deload for a little while, because what we're effectively doing is restarting that healing process. So we're effectively you think about all those old ankle injuries you've got. Well, you can't go back and rehab them in a different way than what you did. So what we're effectively doing is restarting that process. So you don't want to immobilize, because we want the tissue to still be maintained, and we don't want to get a lot of muscle atrophy and so forth. But we'd probably have you in your brace, and we'd probably have you with some relative rest. So not kicking and not doing Muay Thai, probably 7 to 14 days post injection. Because what we're doing is we can't change physiology. The wound healing cascade and the way the body heals, we're not magic. What we're basically doing is restarting that. So when you inject prolotherapy, PRP, or even mesenchymal stem cells, you're effectively in the first few hours, and the first few minutes to hour, you get a little bit of bleeding because of the needling process. Then you get some acute inflammation. So you get some neutrophils in the area, and that will last for usually 24 to 72 hours. And then that kicks off the next phase, which is the proliferation of fibroblasts and tenocytes and other mesenchymal stem cells that migrate to the area to repair. And that proliferation phase lasts for a few weeks, usually somewhere between 2 to 4 weeks. And then that's followed by, they lay down connective tissue collagen, and that collagen takes up to 2 years to remodel. So you got early collagen being deposited, but some of the processes you kick off with a regenerative procedure is still occurring 12 months later, 18 months later.
Okay.
So for your ankle, for example, rather than just sticking some cortisone into the ankle because there might be some synovitis, we would assess all of the structures, your deltoid ligament complex, your spring ligament, your tib post with your perineals, your lateral ankle ligament complex. And then we would find the ones that were deficient or maybe had areas of laxity or degenerative change, and we'd treat all of those, because we're trying to improve the stability of the whole joint complex. The whole joint complex isn't just stabilized by one ligament like the CFL or the ATFL. It's very reductionist to do that.
No, it's funny, because the most recent MRI I had, even when the specialist was looking at it, he said, there's nothing in your ankle you have not injured. Every ligament, you can tell it's been injured so many times in the past. And they were saying the same thing. We can do cortisone injections. And I went, so I put that off. Because I'd heard about this stuff. And even my wife is going, do you know anyone that actually does this? And I said, I do, which was you. So I may make my way down to Melbourne at some stage.
Whereabouts are you based?
I'm in Cairns. I'm so far away from you.
Yeah.
But I always look for an excuse to go to Melbourne.
There's a few docs. I know some in Brisbane. Dr. Paul Scavo in Brisbane. I think he's got a clinic called Ortho Regen or something along those lines. He does a lot of this sort of stuff. But there's quite a few. The other thing to have a look at, there's an association called the Australian Association of Musculoskeletal Medicine. So the upcoming course, we're teaching a course with Craig and Dr. Ramona Cressidas. She's an MSK doc in Adelaide. She is the past president of the Australian Association of Musculoskeletal Doctors,
Yeah.
effectively. So they've got a registry, and there's a lot of, they've all got different sort of areas of specialty, but that's where you'll find people that will tend to practice, because it is that little bit of a paradigm sort of shift there. But what we also would look at as well is, and I'll talk about the nerve type stuff. So
Yeah.
the nerve stuff is, there was a New Zealand-based doctor, Dr. John Liftoff, who's now retired, but he ran courses and he coined this treatment called perineural injection therapy. So Dr. Liftoff, he started off as a prolotherapy doctor, so injecting these hypertonic solutions. But a lot of doctors that work in this space, he practiced on himself, and he was practicing different concentrations.
Yeah.
So he was going all the way up to 50% and then all the way down to 1%. And at the time, I think he was suffering with some Achilles. This is the story. He was suffering with Achilles tendinopathy, and he was trying to treat that. And he didn't really like the idea of injecting deep into his own tendon. So he started doing these superficial injections of different strengths. And what he found is that this 5% solution, 5 to 6% dextrose or glucose, it has this analgesic effect. And the technique that he coined is where we effectively palpate and we look for where sensory nerves pass through the fascia. And these sensory nerves, as they pass through the fascia, there can be areas of constriction. And when a nerve's constricted, it affects the blood flow, and it affects basically causes a metabolic disturbance to the nerve, which causes the nerve to become sensitized, and you get pain effectively. So often when we think about nerve pain in clinical practice, you think numbness, tingling, burning, stabbing, all those sort of symptoms, which is true. But in a lot of cases, it's just poorly localized, dull pain that people don't get a lot of relief from. So what's really interesting with this technique is you're effectively using isotonic, which is 5%, dextrose or glucose, and it's injected only subcutaneously with a 30 gauge needle. So these tiny little insulin needles, and we inject them at multiple tender points. And it has an effect on nerve pain. And it's one of those things that until you do it yourself and until you treat a patient, you won't believe it. It sounds a little bit ridiculous. You're injecting some sugar water and it seems to make people's pain go away, but it works quite quickly. So you'll have patients that are in quite a bit of pain and nerve pain, and it's relatively within 5 minutes that pain will start to substantially reduce. And the course of that, we often repeat multiple times. And then there's
that was going to be one of my questions with all this treatment. It's never probably just a one-off treatment. It's something you've got to do.
It all depends. Yeah, so with the perineural, we often do it weekly.
But okay.
The benefit of that is these are subcutaneous injections. It's isotonic, so it doesn't sting when it goes in, but it's very well tolerated. So it's almost like the same as acupuncture, but you're not even going as deep. So it's really well tolerated. It's a quick, easy treatment to do, and the patients will come back once a week. So the first treatment, there'll be an improvement often in their symptoms, and it can be really substantial. And then some of the effect will wear off. And then when you see them about a week later, they're still better than where they were. You'll do it again, they get a bit better, and you almost get this like dialing down. It's almost like you're turning the volume down on pain. And you will sometimes do this for some patients, it might be 1 or 2 sessions. For other patients, it might be 6 or 7 sessions, where you're doing it until that resolution of pain sort of kicks in. Then there's a more sophisticated version. So with that, you don't need ultrasound. So perineural injection therapy is not traditionally done with ultrasound. It's done on palpation, and there's a technique. Ultrasound-guided nerve hydrodissection is where we still use that 5% dextrose, because this has an effect on neuropathic pain. There's several mechanisms that have been studied, but it seems to affect the TRPV1 receptor, and it also seems to rebalance when there's some nerve constriction or there's some ischemia of the nerve from compression. It seems to address that sort of basically that glucose deficit. So when nerves are really hungry, they use a lot of energy. So when there's a constriction around a nerve, it'll often become hypoxic and hypoglycemic, and that will cause it to basically depolarize and cause pain. So with the ultrasound-guided procedure, what we do is we usually are treating bigger nerves. So it might be the tibial nerve, it might be Baxter's nerve, the sural nerve, superficial perineal nerve. And what we use is fluid to separate the nerve from the surrounding tissue. So it's a really cool procedure where we basically dissect the nerve at the potential entrapment or constriction sites using ultrasound. And so the needle basically doesn't really, it's a very atraumatic procedure because as we're injecting, we're always injecting. So you're actually pushing the tissue out of the way. So
Okay.
you're basically separating. And again, it's a really interesting procedure where you had a lady the other day with a superficial perineal neuralgia, and you treat them. They're in a lot of pain. And by the time they walk to the front counter, the pain's gone.
That's always good.
Yeah. Sometimes with those procedures, it might be a one-off. But if they might have had, say, there's a lady I'm treating at the moment, and and a lot of the time it can be post-traumatic. So she's had a fracture of the ankle, and just due to her anatomical variation, we've got the dorsal intermediate cutaneous nerve where it runs along the fibula. In her case, it comes down quite low. And where the fracture's been affected, it's right next to the nerve. So she's got even 5 years later, the ankle's better.
Yeah.
She's walking fine, but she still has some neuropathic pain when she's in bed at night and when her ankle's in certain position. So we use this technique to effectively address some of that entrapment spot.
Okay. And before we forget, well, we won't, you
Yeah.
have a course coming up
We
in
do.
April. So let's give that a plug. And like you
Yeah.
said, even if people happen to listen to this recording after the course is finished and they missed out on it, because there's only 5 places left at the moment. This is something that you do every year. So they can reach out to you to find out when the next one's going to be if they happen to miss this one.
Yeah, so this one's going to be on the 10th and the 11th of April in Melbourne. It's at the OPC head office in Clayton. And this will be we ran this same course a year ago in Adelaide. So it'll be myself, Dr. Ramona Cressidas, and Craig Wandless. And with this sort of course, we have a maximum of 12 people because it's a really hands-on, it only works in this sort of small group environment.
Yeah.
And it's very hands-on. We bring some live patients in to treat. There's a lot of demonstrations. It's not a show and tell type course. So it's not a course where we get 20 people in and we just show and tell different stuff. It's very much a hands-on course where you need to learn these concepts because you have to learn the skill set to assess these patients differently, to palpate differently. And the thing is, it's a little bit unmooring because if you're used to that real conventional approach where we're just going to put cortisone where the pain is, it's a paradigm shift, and that is difficult. So we usually get a mixture of podiatrists and doctors. So last year, I think we had 3 doctors and the rest were podiatrists. And yeah, it's a 2-day course, and it's basically designed to give you the fundamentals of these techniques. So we run through perineural injection therapy, we run through traditional prolotherapy, ultrasound-guided injections, and the perineural ultrasound-guided hydrodissection, and also nerve blocks. So to do a lot of these procedures, we teach you the nerve blocks because a lot of that overlaps with the hydrodissection stuff. You need to know your nerve anatomy.
So when someone does this course, are the people who are coming along already have an existing ultrasound and then they want to add this as a skill set? Or is this something they learn this as a skill and then if they think it's beneficial, they then go and invest in the ultrasound and what else is needed?
It's both. So this particular course is really anywhere from beginner, so no experience with MSK injections, all the way through to people. We've got some people coming back who have done the course last year or did one of our NUSA courses, where the NUSA one tends to be a little bit more advanced. So the NUSA one's only ultrasound, and you don't have to have a lot of injection skills, but you need to have some ultrasound skills. So this one is really, we will teach both the clinically guided procedures and also the ultrasound guided procedures. So this one's really open to everyone.
Okay. So if you haven't used an ultrasound at all, or only a little bit, or don't know too much about it, this is the course to do because it's going to be like an introduction to it all.
Yeah. So I think, a few years ago, I've got one of the pods that is a friend of mine who come to the NUSA course.
Yeah.
He's got a decent sized clinic and he had 2 handheld ultrasounds. And he still says to me that was the most expensive course he's ever come to because it cost him $90,000. Because by the time he went home, he realized he needed 2 cart-based ultrasound machines. So within a week, it was an expensive CPD course because I needed 2 of them because I've got 2 separate sites.
But it is one of those things that if you see something that you think your patients will benefit from it. So there'll be certain clinics where they don't have the patients coming through that this would apply to. but there'll be other clinics where it will. And I think if
Yep.
this is something that you know is going to help your patients, and if it costs you $45,000 to get the ultrasound, you're going to be using it, and it's a service that you can provide, and it's something you can get better at, and it will separate you from other people in your area.
Yep.
It's an investment in your future and in the future of your business.
Exactly. I couldn't agree more. There's a lot of people that get stuck in, they create something they don't even want, a clinic.
Yeah. Oh,
They've created a clinic and they're like, I'm so busy, but it's all general and I don't really enjoy it. And I want to learn some of these things, but I don't know how to pivot. And the thing is, you're not going to be seen as a clinician who has other skills if you're only doing, you have to do these things in order
yeah.
to be able to offer the service, because it's mostly word of mouth. It's not like I don't spend any money advertising this sort of stuff. The patients that come are coming usually because they have either, I've treated a friend of theirs or a family member or a referral from a doctor. It's mostly word of mouth or referral. And then occasionally some of them come from like a podcast that I might have done on
Yeah.
regenerative.
Like this one.
Yeah, that's it. So yeah, it's definitely something that's worthwhile. And the other thing I'd say, which has been probably the best thing I've ever done, was basically to go to other conferences. So that Interventional Orthopedic Foundation conference, basically a workshop that I did was in Colorado in the US.
Yeah.
I was the only podiatrist there. There was like a neurosurgeon, there was all these basically pain management doctors, radiologists, and I'm the only podiatrist there. And I don't mind doing that. So I was just last year, at the end of last year, I was at the Australian Association of Musculoskeletal Medicine there. They brought out some of the Hong Kong doctors. So Dr. Stanley Land, who really pioneered that technique of ultrasound-guided hydrodissection. So they brought him out along with a radiologist from Italy, Dr. What was his name? Anyway, he's written a lot of the textbooks and things like that. And again, I was the only podiatrist there. They were all radiologists, sports doctors, MSK docs.
I bet you learned heaps.
You learn heaps because you're going out to dinner, you're going to the conference dinner, you're talking to these people in the lunch break, and it's a completely different perspective. Like next week, or the week after, I'm off to a sonography conference. Again, then probably no podiatrists there, but it's good to go and talk to other professions and not just go to all the podiatry conferences.
Yeah, I remember this podiatry conference over in America, and it was predominantly business and marketing, but it was all podiatrists. And the guy, Larry, there that I'd met first year I was there, nice guy, always wearing Hawaiian shirts. And then one day I said to him, this is on the third year, hey, Larry, where is your podiatry practice? And he said, I'm not a podiatrist. I said, what do you mean you're not a podiatrist? He goes, I'm not a podiatrist. I'm an accountant. And I said, how come you come to this? He goes, I learn more at these podiatry marketing events that I can then just adapt to what I do in my accounting business than I'll ever learn at going to a traditional accounting conference. And I think that's what you're saying. You can go to podiatry conferences and learn a certain amount, but if you want to learn some really different stuff and then adapt it to what you're doing, getting outside of podiatry conferences is some of the best things you can do.
Completely. Like I love going to podiatry conferences because you get to catch up with your colleagues, and I really enjoy that. I really enjoy the social aspect of it. But like it was even a few years ago, I went to a workshop which was run by a friend, Dr. Colin. He's a radiologist, interventional radiologist, and he did this workshop with Professor Fred Joshua, who's a rheumatologist. And there would have been maybe 8 of us.
Yeah.
And probably about 8 of us. We had a whole day with basically a rheumatologist, interventional radiologist, and he brought his patients in. So Professor Joshua, he's brought in these patients that we were live scanning, and he was still in the process of working out from sometimes diagnostic, or whether he needed to increase therapy or decrease therapy. And it's like, that is so valuable. That was like 8 hours worth of getting the insight of someone who thinks very differently. You can't get that from an hour lecture on YouTube or a little webinar or a conference where you get a snapshot of a rheumatologist. So things like that are really valuable.
Yeah, I remember going to one once, and it was for general practitioners, practice managers. And I saw this thing pop up and I went, I'm going to go along to that because we happened to be in Cairns. So I went to it, and it was really cool because they were still talking about practice management, they were talking about doctors' surgeries, but there were so many things they were saying, go, oh, yeah, I could use that. I could use that. But then just talking to people afterwards was great. And then by talking to those people, I then got invited to talk at the next one that they actually did in Cairns, like the year later.
Yeah, exactly.
So it's
Yeah.
getting out there and meeting these different people as well. Oh, with your course that you're doing,
Yeah.
where's the contact details if people want to, where do they go to
So
find out about it?
I'll pass it on to you so it's in the show notes.
Oh,
But
okay. Yeah.
there's a registration. I'll put the link to the registration form.
Yep.
And if anyone's got any questions, you can always contact me. It's info@my sports with an S, podiatrist.com.au. So if anyone's got any questions or anything related to that or what we talked about, yeah, feel free to reach out. But I think probably the most active I maybe would be LinkedIn. I don't use Facebook, and Instagram I'm very slack with. So email is probably the best. If to get a response, email is probably the best.
Yeah, no, that's okay. So is there anything else you want to talk about before we wrap up on this particular subject?
No, I think I think it's a really valuable set of skills. And if you're a podiatrist that feels you feel like you're in a little bit of a rut and you feel like you want a different perspective and you want some different techniques, this is a journey that you will only, you never quite master. So I'm probably 10 years into this journey. Ramona's probably 20 years into this journey. Craig. So between the three of us, we've probably got about 50 years worth of experience in this space. So it's as I said, my advice would be if you're feeling like you're a little bit bored of clinical practice, change the paradigm, try something different. And I guarantee you there'll be a lot of things to learn and you'll never feel like you quite master it, but it gives you something to thrive and strive towards.
I think there's a lot of podiatrists that will complain about the type of practice that has developed in front of them, but it's their own fault because they let that happen. And because they've chosen to let that happen that way, if they're not happy, then now's the time to actually make that slight change. Is just do that little bit of a pivot, bring in some new skills, and slowly just start moving your practice in a slightly different direction. And then if you're the business owner, you get to choose this. You can't complain.
And look, my advice, I've been asked multiple times particularly with the shockwave, when I see podiatrists or particularly podiatrists that have a practice that's very like general care oriented.
Yeah.
Particularly if they work somewhere rurally where they're really particularly sort of sought after and they're just booked flat stick with generals and they just don't know how this is going to work. They're like, I want to take a different path with podiatry, but I feel like I'm so stuck at the moment. Like my books are just full of work that it's not that I don't enjoy it. It's just that I'm not feel like I'm stimulated as a practitioner.
Yeah.
So my advice is you actually have to block some time out. So that there are times in the day where you're like, okay, through the middle of the day, I might see some generals, but maybe my first hour and a half or my last 2 hours in the day, and you need to actually allocate some time and say, all right, of my calendar, I'm going to put 5 hours that are blocked out, which you can only book in, tell the reception staff, you can only book in patients that are new patients that are not coming for general care.
Yeah. I know it's actually very simple to do because this is what I teach my coaching clients is about time blocking and what do you want more of and what do you want to stop seeing? And it is so easy to do. And some people go, oh, but I'm booked out 3 months. Great. We'll start in 3 months. Go ahead, do 3 months in your diary, start blocking it now. And they go, oh, yeah, but. And as soon as I hear them say, yeah, but, and then I'm just waiting for bullshit excuse in brackets to come up because they constantly just making excuse because most people don't like change. They'd rather just complain and just stay in homeostasis because it's so much easier.
It's true. And if you're a practitioner who's starting out for the first time, I think, and again, look, everyone's different. I'm not saying the way that I did it is correct, but when I started out, I went out on my own. I basically self-funded it. So I had no debt.
Yep.
And I'm not saying that's what you need to do, but I've never had debt in business when it comes to capital purchases and things like that. And there are reasons why your accountant might say it's a good way to do it. But in an early phase, when you're starting out, it means that you're not under financial pressure. So effectively, like you're paying yourself back, you're the lending agent if you've got some capital behind you. But the benefit of that is you don't ever feel like you have to do something because you've got
Mm,
basically bills due.
great
So
point.
that allowed me when I started my practice to say, okay, I this is going to be a musculoskeletal practice. I'm not going to do routine podiatry or diabetic foot assessments anymore. And you could say no because I didn't need to pay. The bills are
Yeah.
relatively modest. And that's a big difference because you didn't feel like you have to basically just do everything and do all of the type of work that you no longer felt rewarding.
And that's why I tell people sometimes who are thinking about setting up their own practice, there's a lot of people I tell them, don't, I'm not saying don't open up your own business, just don't do it now. Wait another 12 months, wait another 2 years until you've got some money behind you,
Yeah.
because cash flow is king. If you've got money and, like I said, you don't have debt and you don't have financial pressures, and if a patient didn't walk through your doors for 6 months, you don't care because your lifestyle is actually taken care of. You will set up the business you want to set up. But
Yeah.
if you start your own practice too early, borrowing money to set it all up right from day dot, there's pressure on you.
Yeah.
And they're the clinics that tend to take so much longer to actually grow.
Yeah. That's it. And you can let things just naturally start to build as well because you don't have that financial stress that I've got. This practice has to generate so much money so I can meet the repayments for my shop fit out,
Yeah.
all the equipment that I've just bought. So yeah, that also does make a difference. So if you're a new practitioner, what I would say is there are definitely some ways to open up where you're not basically underwater before you even start and you're not stressed financially before your business has even started generating some cash flow.
And the thing is, I've done it both ways. I've set up, like, over 30 something years, I set up a lot of podiatry clinics. Some I went into debt to set them up, and some I had the cash sitting there to just go and do it. And the ones where I didn't have any stress because of cash flow ran smoother. And then one of the last ones that we set up, I remember it was years ago, down in Mackay, and we went, that's it. We're not going to do any routine foot care, just sports, biomechanics, athletics. That's all we're doing. We set it up, and we were having people ring up and say, oh, can we book in? We see that you've just opened. No, we're not doing that. No, we don't do home visits. No, we're not going out to any nursing homes. We just stayed focused, and we just absolutely killed it by just focusing on the stuff we really wanted to do.
Yeah, I think everyone tries to do everything. It's like I do pediatrics, I do wounds, I do IB, I do that. There's a massive need for that. There is a need for the generalist that does everything, but it's a free market, and you can create a product and a service that you want to bring to market. Like I see on LinkedIn quite a lot. Practitioners, and this is doctors, OTs, speech pathologists complaining about Medicare, NDIS, and
Yeah.
changes in funding and rates that haven't gone up and things like that. And you go, I don't really have a lot of sympathy. It's you created a business, honestly, if you've created a business that is purely based off third parties, it's a stressful place to be because the government can change the policy at any point. They
Oh,
cannot
yeah.
rates. You've they've got to basically your expenses may go up each year with inflation and with different cost of business. And at the end of the day, government might choose we're going to only pay this much.
Do you know how many podiatry clinics would just crumble if they weren't getting their bulk billing patient care plans?
Yeah.
It's there's this quote, I've got it in front of me here. It says, there's no such thing as a true generalist, or if there is, you won't have heard of them.
Yeah.
So I do think, like, I think you can have a routine business quite easily. You can have a very successful routine business. But if there's something you really enjoy doing, even if it's only 10% of your day, it's going to make your podiatry day more enjoyable.
Yeah. Because and there are a lot of examples. If you're a GP that is not satisfied with the way the conventional process works, where you're seeing patients for 10 to 15 to 20 minutes and you're constantly working off that, there is a demographic of people that want to pay for an hour of a doctor's time because
Yeah.
they're not happy with that sort of transactional healthcare. It's
No, it's
expensive,
true.
but there are a lot of doctors that have either gone into the regenerative medicine side of things. That's all they do now, and they are booked out. Ramona, who we teach with, Ramona hasn't taken new patients for 5 years. Her books are closed.
Yeah.
She was a GP by training. So there is a demand, there is integrative, there's functional medicine doctors who effectively bill properly for their time, and they are booked out and patients want that level of care. So at the end of the day, it's if you're dissatisfied with what you're doing, create the product or the service that you think the public will want. Find out if they'll pay for it.
Yeah, but I used to tell my GP, I would pay 3 times more if you could get me in and out on time.
Yeah.
And he said, would you? I said, I would pay 3 times what you charge if you could get me in exactly the time my appointment was and get me out exactly when I'm supposed to get out. I would pay 3 times more. I said, because my time is far more valuable in my podiatry clinic than just be sitting in your reception area. And he went, oh, so he started doing that and was making more money and seeing less patients without all the headaches and everything that went with it. But when we're talking about people that just niche down a little bit, I've got like James Ferrie. He was into wound care. And I remember when he was on the podcast, it was back episode 29, and he said it was probably only about 10 or 15% of his workload was that. But that's what he was getting known for. And that's what I know he's spoken at different events. Rebecca Rushton, at episode 83, she was right into blisters. So it wasn't a whole practice, but it was something she really was interested in, and bang, went down a rabbit hole on that particular topic. So I think if you want to make a change in your practice, you're the person that makes the change.
That's it. And the thing is that the opportunities just tend to present themselves. So I think the first time I met Ramona was at a dissection workshop in Sydney. And we met through a mutual friend, Jackie, who's a podiatrist in Melbourne. And you just go, it's just interesting. And then from there, we now teach a course together with Craig. And you have to sometimes step outside that comfort zone, and different opportunities present themselves.
Yeah, definitely. Okay, James, I want to thank you for coming back on the Podiatry Legends podcast. Always fun chatting with you. Yeah, it's always interesting. What you talk about is actually really interesting stuff. And because I'm at the back end of my career, so I'm almost on the way out, unless 60 is midlife these days, which I don't think it is. But I think anyone younger who's listened to this podcast, or you could be my age and you're planning to work until you're 80, I think you should take a further look at all this. So, James, thank you very much.
Thanks, Tyson. Great to chat again.
Well, I hope you enjoyed listening to James Ferrie today. And what I loved most about this conversation is that it reminds us of how wide and interesting the podiatry profession really is. It's very easy to fall into a routine type of practice. You get busy, your books fill up, and before you know it, you're doing the same treatments day after day without really challenging yourself. James' journey is a great reminder that you can always pivot. It's never too late to pivot. You can learn new skills, and you can take your clinical career in a completely different direction if you choose to. He didn't just attend one course and stop there. He kept learning. He traveled overseas. He spent time with experts in other professions and invested in equipment and education that allowed him to offer a different level of care to his patients. And that's something I talk about all the time. If you want your practice to evolve, you have to evolve first. The type of clinic you end up with isn't something that just happens to you. It's something you deliberately design over time. And if you're feeling a little stuck in your clinic right now, maybe a little bored, or maybe you're just understimulated, it might be time to explore a different direction. That could be learning a new clinical skill like James has done, maybe introducing new technology, refining your niche, or changing the type of patients you attract through marketing. Small pivots can completely change the trajectory of your career. And if that's something you've been thinking about, but you're not quite sure how to make that transition, that's exactly the type of work I help podiatrists with through my coaching and mentoring. Sometimes all it takes is a fresh perspective, a few strategic changes, and a clear plan to just move your practice in the direction you actually want it to move in. Now, if that sounds like something you'd like help with, please go to my website, tysonfranklin.com, click on the coaching section and just follow the instructions. We can have a chat about where your practice is right now and where you want it to go, and what steps might help you get there just a little bit faster. So before I finish up, I just want to remind you, if you enjoyed this podcast, please consider leaving a rating and review on whatever podcast platform you happen to be listening to this episode on right now. So that's it from me this week. I want you to look after yourself, look after your family, and I will talk to you again next week. Bye for now.